Hey, it's Dr. Centeno, and thanks so much for joining me. I'm not in my usual location on this Thursday, so you might notice a difference in background here. We're going to be talking about some interesting stuff today, which is really, at the end of the day, what's up with rare worsening after an EPICL procedure. This has been an interesting topic because it's one that kind of ebbs and flows every 6 months or so. We tend to see what I call patients hitting the panic button about every 6 months. And like all things on social media, that tends to ebb and flow and come and go. So we're in a wave of that right now. So I thought I'd bring this up and address this and try to get into what I think is going on. And after taking a look at all of this, what I think is happening here. So as usual, we'll start with a presentation, probably going to be about 10 minutes or so. And then I invite you to start putting questions in the comments, no matter where you are, whether you're on YouTube or Facebook. And realize that if you get your question in sooner, it's more likely I'm going to get to it because we tend to get a lot of questions as time goes on. And consequently, if you sort of ask your question late, I may not be able to get to it by the end of the 1 hour Facebook Live or YouTube Live. So if you're just joining us, we're going to get into what are the risks of worsening with EPICL, and then I'll get into the usual Q&A here. So let's start with, my actual day-to-day world of treating hundreds of CCI patients a year really looks like the as seen dashboard. And this is one of the reasons why I started doing this as seen dashboard. What does that mean? What that means is that every patient for about the last 10 months or so that has come into the clinic to see me, and now more recently, Dr. Schultz and Dr. Pitts, we log on an Excel spreadsheet and we get their percentage, what's called SANE score, 0 through 100% better. We record their symptoms, their CCI type, etc. And this is good because it gives you all a vision into what I experience every day seeing these patients in the clinic. Now, the ones on here are the ones that actually have an outcome, right? So it's not all the patients I'm seeing. On any given day, it's about half of them or so, sometimes a little less, sometimes a little more. But these are the patients that have come back for a second procedure where we can record an outcome from the first procedure. So those are all over Reddit. I invite you to take a look at those. But, as you can see, these patients are doing fairly well here. About 47% improvement in 1.7 treatments, 31% improvement on average per PICL. So that's my day-to-day. Now, there are patients in there that don't respond. There are patients in there who had big flare-ups, and we just let it all hang out. That's where it all is. I haven't yet posted this week's total spreadsheet of all the individual entries, but I'll probably get around to doing that here. I'm just traveling right now. So the question of flare-ups with EPICL, as I brought up before, tends to come up about every 6 months or so, and it tends to come in waves. We kind of had the rare prolonged flare-up in sensitized patient wave, the rare reactions of OTC patients wave, the rare improvement and then worsening wave, etc. So we get these waves, and since we're in one of those waves, I thought it'd be a good Facebook Live topic. So it's important to note that you don't really have to be a doctor to understand. You can see this every place, that any therapy, drug, procedure, or surgery can worsen a patient's symptoms. So that's important to understand when you're dealing with a chronic pain or a chronic disability or disabling condition. That's critical to know. Now, the good news is with EPICL, it's far more rare than something like surgery. With conservative care like upper cervical chiropractic, it's very rare. Happens, but very, very rare. Now, the most common perception of worsening, and one of the original ones that we've been following for quite some time, is this prolonged flare-up. And when patients come in, this is exactly what I tell them, or if I see them for a telemedicine, that your flare-up after, or your recovery after a procedure, is going to follow a bell curve just like this one that you see here. And what you're seeing there is basically most patients are flaring up for about 7 to 10 days. And then we have some patients that are taking shorter or longer, 3 days to 3 weeks. And then we've got a very small number of patients that have no flare-up at all, or no noticeable flare-up, or extremely small, or even months of a flare-up. Those are rare cases, but they happen. And so if you're on the tail end of one of those longer term flare-ups and you're one of those rare patients, then that can be very frustrating. It's very easy to hit the panic button. And we'll hear about the panic button in a minute and why it's so important to try to avoid hitting that panic button. Now, the good news is that prolonged flare-up issue seems to have been mostly addressed by what I call the less is more approach. So if we detect that someone is centrally sensitized, we will then go ahead, and that's on hands-on exam, and dial back the procedure aggressiveness. So I just did that this week. I had a patient on exam. It was very clear she was centrally sensitized. We dialed back her treatment, meaning I did about half as much of her treatment as I would have expected to do, because I knew that she was a high risk for a prolonged flare-up. Now, another common concept that's been making the rounds that is sort of adjacent to this concept that we're talking about today is the idea that somehow some patients can get a worsening of instability through injection. And the reason why I have a question mark here is that's an interesting one, because it's one that's not supported by any peer-reviewed literature. It's not supported by any mechanism of action. So there is no data that shows that an injection of orthobiologics into a ligament makes that ligament weaker, nor does that make any biologic sense. There's just no mechanism to describe it. In fact, the mechanisms describe the opposite, that at around the 2-month mark, let's say, that ligaments are getting stronger, not weaker, after an injection of orthobiologics. So why would a flared-up patient think they were more unstable? Well, it's probably pain inhibition. So pain inhibition means that when you're in a lot of pain in a certain part, or if you have a lot of symptoms that are being generated by that part, that your body shuts the muscles down or inhibits them in order to attempt to basically reduce the harm to the area. And this will make you feel more unstable. Now, I've experienced this myself. I have cervical stenosis and a couple of disc bulges in my neck. Never got surgery. I've been treated through the clinic off and on at various times through the years. But there was one time I was seriously considering surgery, and that was when this happened to me, where I got pain inhibition or muscular inhibition of all of the stability in my head. So bad that in order to get off the couch, I literally had to grab my top teeth and lift my head with my hand through my teeth. Now, thankfully that resolved, but it's that kind of stuff that would make someone believe that all of a sudden their ligaments weren't holding anymore. That wasn't the case with me at all. What really happened was that my muscles had shut down. And for me, what probably happened is the dura, or covering the spinal cord, got banged into. And as a result, it was pretty scary. I was sitting on the couch saying, I don't know how I'm getting off this couch, other than to literally, again, grab my top teeth and use it to support my skull to get off the couch. Another thing I think we're seeing with the most recent trend here is obviously there can be accurate reporting by someone on social media of what's going on with them, and there can be inaccurate reporting. Now, the inaccurate reporting I don't think is in any way diabolical or anything like that. I think that patients, however, have a different perception of what's going on. So we just talked about one of those different perceptions, that perception that somehow because I've got pain inhibition, my ligaments were made weaker. No, muscles are shut down. But I want to go through one of these in a way that's sensitive to the person. This happened within the last 6 to 12 months. But I think it's illustrative because, like all of these cases when they happen, I got to pull everything and just take a look and say, God, what's going on here? So these descriptions will be purposely vague to protect the patient's privacy. This was a social media post. The patient reported in that post that she was very functional before due to some posterior injections and just wanted to get a little bit better. And the claim that was made was that about 2 months or so after the EPICL, the patient suddenly became so unstable that emergency fusion was needed to prevent paralysis. When I saw that, I was like, wow, that's super interesting. Emergency surgeries are certainly done for fractures. They're certainly done for dislocations after huge car crashes, but emergency surgery is almost never done on an elective CCI patient ever. So I was really interested to pull the information on this one. So a different patient had reached out to me about the post, and I just pulled everything. I had enough information. You know, we only treat a couple hundred EPICL patients a year, so it's not hard to identify someone if I have a little bit of information. So I did that, and then I pulled all of the imaging, registry forms, records, and spoke to the physician who performed the EPICL. We even spoke to the surgeon, trying to figure out, hey, are we smoking dope here? Is there something we don't know? So this was quite an extensive investigation over a couple of days to figure out what was going on. So the first thing that had me think to myself that this might not be an accurate report was an email that the patient's spouse had sent to the treating provider. And again, this is highly paraphrased here. So this email was sent after that instability flare-up, and the spouse had relayed that the patient had a severe mental health crisis after the posterior injections. So this concept that posterior injections were all roses was not accurate at all. The husband said, listen, there was a severe mental health issue after the posterior injections, just like is happening now. And so you really should, doctor, you really should be aware of that this has happened before. And the spouse relayed that the patient really believed that their head was going to fall off, but refused to rest. The recommendation was to rest. That wasn't happening. And also, the spouse relayed that the claims weren't supported by the CCI experts. Now, the CCI experts that were consulted here were world experts in CCI and recognized as world experts in CCI, and none of them were really confirming what the patient was reporting. The patient was reporting to their spouse that the C1 had fractured and was sticking into blood vessels, but there was no imaging at all that demonstrated that any of the world expert CCI people, and we're not talking about your average neurosurgeon or your average physical medicine doctor or neurologist who just doesn't understand this. We're talking about the people that see these patients day in, day out. So that was interesting. So another claim was that the patient was highly functional prior to EPICL. Now, one of the things we can do very easily is to pull this information. And so we use the Neck Disability Index, or NDI. NDI is a validated functional questionnaire. That validated functional questionnaire allows me to see the exact disability on the day that before the procedure. And so this is the scale. I won't give you the score because I don't want to, I want to protect this patient's privacy. But it was the score on the day of the procedure was high severe disability. So again, that doesn't fit with, I was highly functional prior to the PICL at all, because that's almost as high as that score goes. This is a validated functional questionnaire. It's been used in research for many years. So that's an accurate reading of the patient's disability. And again, this is before the procedure. So that didn't really fit. And then finally, we called the surgeon because I was like, this doesn't really make sense. And now we've got all these red flags here. So the surgeon was called and we just asked the question, hey, what do you think? Was this person about to be paralyzed if they didn't get an emergency fusion? And the surgeon said, absolutely not at all. There was no emergency other than the patient created an emergency by demanding fusion yesterday. Basically, that's what caused the fusion to happen quickly. There was no imminent risk of paralysis in this patient. There was no evidence that the PICL had caused instability. There was nothing different about that surgery than any other surgery for any other patient that he had seen as one of our patients. So again, none of this added up. And so here I think we had clearly inaccurate reporting, right? A disabled fusion candidate tried the PICL, had a flare, pushed the panic button, and then ended up with a fusion. Now, regrettably, we can't learn all that much from inaccurate reporting. But what can we learn from what I call the panic button tragedy? The first is that flare-ups happen. The second is that just because you have pain inhibition doesn't mean that you're more unstable. That's an important one. And the first thing I ask patients, which is very, very common, is what meds did you stop prior to the PICL that were helping? This is probably the most common thing that occurs, right? We tell patients to stop certain medications. They stop those medications. And then when a flare-up happens, they don't have those medications to fall back on, or they needed those medications just to function prior to the PICL. So at some point, we tend to, in these kinds of patients, restart those meds and get an apples to apples comparison to see where they are. But that's a very, very common one. The next is pretty obvious, right? Did you do something? Did you fall? Did you do too much too soon? In the patient we just reviewed, I think it was a lot of too much too soon. And then we can always get a routine MRI to make sure that nothing big is happening or is amiss. And if I had to give one point of advice, it would be, in the rare event this happens to you, don't panic, because I think panic tends to put you in a situation where you get the most invasive treatment, whether or not it was the right treatment for you. So in summary, I understand that patients have been suffering for a long time. They often feel isolated, that nobody gets what's going on with them or what they're going through. Having said that, in the rare event this happens, when the world's leading experts in CCI are telling you that it will all be okay and you'll get through this, don't hit the panic button. Take a breath, take it easy, and let's work the problem rather than push the medical system for the most invasive treatment possible. Okay, let me stop that sharing here and see if I can get to some questions. Raj, hi doctor, do you check if your patients have CSF leaks? Is something good to rule out? You know, CSF leaks are always possible in this patient population. If you had to look at the Venn diagram of the symptoms from CCI and the symptoms from CSF leaks, there's big overlaps between those two. So at the end of the day, the first thing I do is to try to make sure a patient's symptoms don't fit a CSF leak. And so just so you have a sense of it, a CSF leak in terms of symptoms is you get a severe ice cream-like headache when you're up, you go to lay down, it goes away. If you're laying down and turning your head side to side or doing stuff with your neck, CSF leak doesn't change, or your symptoms shouldn't change from a CSF leak. So that's probably the biggest thing we do first. Now, we have some patients where we're not sure and they're going through a CSF leak workup. So we tell them to complete that workup before considering a PICL procedure. Johnny, do you think it's a lack of education that's provided that's causing the, I don't know, the PICL procedure, but maybe this phenomenon? Yeah, I think it's a lack of patient education. I think it's a ton of rabbit holing that happens on social media. I think that it's a lot of all of the above, right? It's someone pushing the panic button. It's someone who didn't really do their homework about what's going on, or maybe they listened to too many people who tried to interpret their images online, or they're not listening to the experts, but they're getting bad information from somebody else. It's all of the above. Hey guys, do me a favor, give me a like, share, comment, subscribe. That's how people who aren't here tonight, who have CCI, get to ask questions so that they can find this type of video out there. Next question. Aaron, how could potential CCI explain POTS, dysautonomia, and different size in pupils? Yeah, Aaron, I've got a few different videos on that. POTS and dysautonomia are normally caused in CCI by irritation of the vagus nerve, usually by the transverse process of C1. As far as different size in pupils, that's usually the cervical sympathetic complex that gets irritated in the upper cervical spine. I've got a few videos on that. If you just go to my YouTube channel and type in pupils, it'll probably come up, or type in vagus nerve. Gotcha. Yeah, panic in the PICL population for Johnny. Yes, Johnny, I gotcha. Hi, Dr. C. I have a PICU scheduled at the end of January. I've been holding my adjustment since around Halloween from Dr. Rosa. Does it make a difference in outcome and how long you're holding an adjustment? You know, I think that's always a net positive when you're holding your adjustment longer. You know, realize there's sort of two different related concepts there, right? One would be that someone can generally hold an adjustment and that they don't need to be constantly adjusted. The other would be that they have, when pushed to end range, craniocervical instability. So realize that one of the ways that many people who get adjustments hold their adjustments is that they don't move. They put a cervical collar on, or these are the patients I see that live like this. They're told by their upper cervical chiropractor, don't move. Obviously, that's no way to live. So there's holding your adjustment, and there's instability when you push yourself or just try to do normal range of motion. But I think that's good, certainly, rather than bad, right? Because if you're holding an adjustment, it means we got something good to start with. Good evening, Dr. Centeno. What can I do when I have a feel daily nerve crawling underneath my scalp, or a nerve crawling feeling under my scalp? It's never irritation. Yeah, I mean, that's probably irritation of the occipital nerves in all likelihood that's causing that sensation. There's a third occipital nerve back here, a greater occipital nerve, a lesser occipital nerve. All of those go into the head and scalp region. And so that's probably what's happening. What do you do? Well, if it's being caused by CCI, you got to treat the CCI and the nerves at the same time. If it's not being caused by CCI and it's just occipital neuralgia, then usually it's an injection of orthobiologics under ultrasound guidance around that specific occipital nerve. Finnegan, how long does it take to get EPICL treatment after a telehealth consultation? You know, Finnegan, that really depends on a number of different factors. So for example, over the last month or so, I opened up another PICL slot. And so it was a bit easier for patients to get on my schedule. Traditionally, it's been quicker to get on Dr. Merkel's, Dr. Pitts, or Dr. Schultz's schedule than my schedule. It takes longer to get on mine. And that also can be dependent on the time of year as well, right? Because I do take a sabbatical on the shoulder seasons there. Ryan, is there a phase in the healing process after PICL where you feel more unstable than normal? If yes, then why? Yeah, Ryan, I think usually what we describe as the donut hole, and it's not really feeling more unstable. I think it's important to separate the concept of symptoms from instability, because they're often divergent at some point. The symptoms are being caused by irritated joints, pissed off nerves, etc. Now, the instability may have caused that, but at some point, those issues can take on a life of their own. So realize that when you have increased symptoms, doesn't necessarily mean you're more unstable. Now, if you feel more unstable, then that could be that muscle inhibition that we're talking about. But normally, what would happen is what's been described as the donut hole, right? You get that swelling in the ligaments initially. It feels very stable, even though it might hurt. Then that swelling goes away after 10 days, 2 weeks, and you feel a bit more unstable or more symptomatic until new tissue starts to get laid down in months 1 and 2, and then remodeling in months 2 and 3 and 4, etc. HFBHJ. Is it possible to have hypermobility in some neck ligaments, but not all? I have HEDS, but I'm very able to hyperextend my neck, but can't extensively rotate it or flex it. Yeah, it's possible. I don't think we've identified all the different subtypes of hypermobility yet. There are many. I've seen subtypes, for example, that involve more the cervical spine than lumbar spine, more the axial spine than the knees and the elbows and the hands, etc. What you could be experiencing there is hypermobility in the neck and then some protective muscle spasm when you do things that cause more instability. That's very possible. Is this video going to be saved? Have to sleep? If so, where? Yes, it'll live on Facebook for a month, as that's my understanding at least, and then it'll live on YouTube forever, or not about forever, but for a long time. Caleb, is it possible for someone to have alar ligament laxity but no overhang? If so, what would prevent C1 from not slipping past C2? Usually, overhang is a surrogate measurement for alar ligament laxity, also accessory ligament laxity. Now, is it possible that someone has that but doesn't have overhang? It is possible. You can get not enough range of motion, for example, in the test. You can also get protective muscle spasm that won't show overhang. The biggest thing we notice there, because we can see it during a procedure, is every once in a while, not often, maybe once or twice or 3 times a year, we'll see someone who has a normal atlantodental interspace inflection because of muscle spasm, because when we put that person to sleep and a little bit of flexion, the muscles relax and the ADI opens up. So it's not common, but we do see it happen where the DMX is normal, but in that case, the ADI is opening up when the person's asleep. So it's probably the same thing for overhang. Blessed, how is jugular vein compression treated? Blessed, this is something you may want to research in some of the videos, but basically having a decreased size of your internal jugular vein is very common in normal patients that have no symptoms. I think what causes symptoms in many CCI patients is the intermittent compression of the internal jugular vein that's happening with motion. So the way to get rid of that would be to reduce the motion, improve the muscular stability. At the same time, the internal jugular vein may not be causing any symptoms at all. And the symptoms may be coming instead from upper neck joints, nerves, etc. So treat those. On my DMX, information for C0, C1 instability is left blank. How do we determine if there's an issue that needs to be addressed there? or can most all C0, C1 instability types be addressed during EPICL? I don't know about your DMX report or what that means. I would say that a DMX tends to under-report or under-determine C0, C1 instability. And that's usually better picked up on an upright MRI with flexion extension. Having said that, you don't need an upright MRI with flexion extension in all cases, because during the hands-on exam and the history in the office, we can usually get to substituting for that information. So for instance, I can tell at exam and in history whether or not someone's probably got a type 1C and hit those ligaments, for example. And that's a 0-1 issue. TT, since EPICL is relatively safe and untreated CCI can worsen, especially since PT and prolotherapy often fail, could EPICL be used preventatively to strengthen ligaments and prevent progression? Yeah, EPICL is for patients who are fusion candidates, and that's important to us. Now, every once in a while, we will bend that rule a little bit. I was talking to one patient on telemedicine this week where they were clearly disabled by this, but still able to work. And their biggest fear was that they would get worse enough where they wouldn't be able to work and earn a living anymore. So that was one of those rare exceptions where they definitely were a fusion candidate based on the metrics, but they weren't a fusion candidate on that day based on their functional disability. And now knowing the safety profile of EPICL, it was a reasonable application of it to say, hey, we're going to try to treat this a little bit more preventatively, because I certainly understand that you are fully able to do your job right now, but your biggest fear is in fact that you might not be able to. Thank you for taking the time to address this. It was blowing up on Facebook. Yeah, again, like I said, this stuff goes in waves, Greg. I see it all the time. It's about every 6 months or so that it tends to blow up in one form or another. And again, you know, I get why it does, because patients are feeling very isolated, alone, it's scary, etc. Having said that, one of the downsides of social media is that it's not most of the voices that get listened to. It's the loudest voices that tend to get listened to. And that was one of the reasons why I did that as seen case series, to say, guys, this is what I see in the office. I know what you talk about. And there might be, you know, some people out there that are screaming from the top of their lungs, but try not to listen to the people or the person screaming fire in a crowded room. Emily, can you treat ribs and left side thoracic at the same time? I've been diagnosed with TOS, in addition to everything else, with EDS, and they can't figure out the cause. I wonder if instability may be the factor. We can, yeah. So it's not uncommon that we'll treat the thoracic spine or ribs when we're treating the upper cervical spine with an EPICL procedure. In addition, realize that many times the TOS symptoms will go away once we stabilize the upper neck. But if they don't, we can also treat the thoracic outlet as well. Elizabeth, I have a swollen knee for 10 years, on and off pain in my knee. The x-ray didn't show any damage. Bones report excess fluid in the knees. I suffer with stiffness from the knee down. Gotcha, Elizabeth. I don't see a specific question in there, but if you think of one, just pop it on in here. Steve, Dr. Centeno, 17 past midnight in Lisbon, Portugal. Well, thank you, Steve, so much for being here at such a late hour. I do know that, having spent a lot of time in Spain and Italy, that you guys have a later schedule than we do, for sure. In fact, I distinctly remember going to dinner in Spain, and we could always get a reservation at like 7 p.m. because the kitchen opened at 7 p.m. And basically what they would tell us, you know, being silly Americans, they would say, well, guys, you can come in at 7, but you have to be out of here by 8:30. And we're like, okay, why 8:30? I mean, we'll be out of here by 8:30, but why 8:30? We're just interested. Oh, that's when the real locals start coming in 8:39 to eat dinner. So I understand you guys have a later schedule. Kevin, good evening, Dr. Centeno. What can I do when I have a daily crawling? I got that one already. Curious what you do to fix your neck stenosis causing muscle inhibition, causing neck weakness feeling. Yeah, so what I did was, there used to be that commercial, right? I'm not just a hair club president, I'm a hair club user or something. I did what I recommend that you guys do. I had the doctors in my office do platelet lysate epidural. We tightened down the ligaments in my neck. We treated some of the facet joints. Periodically, every couple of years, we tune it up, and I'm good. I do a lot. So I would say my neck is a generally weaker area, but I'm getting old. There's a lot of weak areas when you get old. Is the detectorial membrane typically able to be injected if C0, C1 instability is suspected? Yep, did that twice this week. Steve, I ruptured C5 through 7 in 2006 wrestling, was recommended fusion, did not fuse to gear off wrestling and return to wrestling and training with that incident. Yeah, Steve, I think what you bring up is very accurate. It's a lot like my story, right? What's really super interesting about my story was about that same month that happened to me, where I had severe issues in my neck for the first time in my life. We had a family friend, friend of one of our kids knew their kids, etc. And she had the same thing, but didn't have the patience to do orthobiologics. So she got surgery. She's got a neck fusion. I don't. And I don't know how she's doing now because she moved away. But it was interesting. She pushed the panic button, got the fusion. I waited it out, did orthobiologics through the clinic, and never looked back. Liz, would too much too soon push someone into something that bad, or just need to rest? Also, do you feel the patient was a fusion candidate prior? Definite fusion candidate prior, for sure. And resting would have been good. Not pushing the panic button would have been good. Perhaps coming in and getting some additional treatment might have made sense. Maybe restarting some of the meds from before. Having the spouse's input would have been helpful as well, to kind of balance it all out and say, hey, this has happened before in you. And I know you're looking back fondly, thinking that you were better, but if we look at this neck disability index, you really weren't. You were horribly disabled to begin with. Let's see here. Can impairment of only cervical colic and cervical proprioception cause the head to feel like it's weighing down? So can impairment of position sense, which is really what proprioception is, cause the head to feel like it's weighing down? Not usually. Usually with position sense or proprioception, it's dizziness and balance, that kind of stuff. Now, what can cause a heavy head sensation is the atrophy of the upper neck muscles that we commonly see in almost all of our CCI patients. If you've had a telemedicine with me, you know that I'll go through that usually on the MRI. And it's that atrophy that causes that heavy head feeling, or feeling like your head's weighing down. What meds would they have to stop? And so much pain with HEDS, morphine patch, and sometimes pregabalin, but trying to replace them exploring ketamine. What should I do? Yeah, Emily. So usually the kinds of meds we're talking about could be things like that, but a lot of times it's nonsteroidal anti-inflammatory drugs, or another common one is some of the CGRP migraine meds that have to be stopped. Those are both anti-inflammatory for the procedure. Now you're talking about another edge case, which is someone who's on narcotic and chronic narcotics. And how do you get someone off of those chronic narcotics? That's a harder issue, because now we're not just talking about feeling bad, but we're talking about withdrawal, etc. So that's such an edge case, meaning it only happens in a few percent of our patients, that usually we'll keep patients on those meds, but have to recognize that person may be very hard to keep asleep. So just realize that that's a sort of a one-off type thing that we'd have to discuss. Hannah, PICL fixed my CCI. Thank you, Hannah, for giving it a shout out. Jonathan, I turned my head while driving suddenly, tunnel vision and tachycardia. Does that indicate early instability? I mean, there could be lots of things that could cause that, Jonathan. So one of those, I mean, let's go through things that should be ruled out, right? One of the things that should be ruled out would be a vertebral artery problem, vertebral artery dissection, that kind of stuff. But usually a routine MRI can rule something like that out. Assuming that's not there, then there may be some craniocervical instability involved. It may just be an injury to the high upper neck and those joints or nerves. I can say I felt my skull slide on the right side backwards, my muscle system all over body tightened down so bad, no paralysis, that maybe that person had other issues. Yeah, so again, I think what you're talking about is that muscle inhibition stuff, and it can be scary. Like I said, I spent a night on the couch trying to figure out how I was going to get up, because I couldn't. My neck muscles just were offline. Anali, can you touch on what the possible side effects PICL not working are? Not sure about the second one, but I can certainly do the first one. So when it comes to possible side effects for PICL, one would be the things that concern us would be a deep infection. Haven't had one in over 2,500 cases, but it's theoretically possible. Hitting a structure we're not supposed to, that might be critical. Again, in a PICL procedure, that hasn't happened, but it's theoretically possible. Another thing, probably the biggest concern, is trying to manage that long-term flare, because that's the one that I think we've seen and verified that can cause some havoc for somebody. And that's just, again, that less is more type approach to try to manage that. And that's been working fairly well in managing that prolonged flare-up. So those are the big ones. Now, another one would be possible unknown things that we don't know about, but once we've now gotten into the 2,500 procedure range plus, it's harder to imagine that there's a lot out there we don't know. Tommy, doing too much too soon. Have there been any studies, inform or otherwise, on what happens when you load tissues that are in early phases of healing after BMC injections? Tommy, there's studies on animal healing. What's super interesting is way back in the day, when physicians were looking at how microfracture, for example, microfracture is when someone's got a hole in their cartilage, the doctor goes and pokes holes in the bone to cause bleeding of bone marrow stem cells into the area and to try to patch the hole in the cartilage. So when a human surgeon went to Colorado State University, one of the best vet schools on earth, the vet surgeons kind of laughed at the human surgeon, and because he said, well, what do you do to immobilize your patients. Tell me about your immobilization routine. And they looked at the guy like he was crazy. They were treating horses. You can't do that with a horse. You can't even do that with an animal. You can try to keep an animal down. You can try to keep a horse down. If you try to make a horse not move, you can kill the horse. So that wasn't an option for them, and their horses healed fine. In the same way, if you ever watch a dog who's had surgery, the dog knows to not do a lot. Now, you've got to kind of restrain them a little bit. You got to try to not put them in situations where they can hurt themselves because they can get overexcited. But animals and us were really built to heal on the go. And so you certainly want to take it easy, but that's why the thread the needle concept exists. You want to push yourself enough where you're loading the structure so the body understands how strong it needs to be, but without damaging that structure. And the way to do that is to listen closely to what's going on with your body. If you're getting very sore from doing something, then back off and thread that needle between whatever activity that is that you can do, no matter how simple or trivial, that might help you load without pushing yourself over the edge. Do you have a list of DMX places that offer these x-rays? There is. If you just contact the office, they can provide you the list that we have. We also now do DMXs in the office, in our office. In which scenarios is it recommended, Elvin, to do PRP or PICL before Atlas correction? Usually not. I would try Atlas correction and upper cervical chiropractic as conservative care or a first line of treatment for this problem. Or possibly better to get Atlas corrected after. I think before, and see if it works. And if it works, great, but only temporarily, then you might consider something like EPICL. Also important not to panic if you have HEDS. I thought I had CCI, DMX, flexion extension, rub one of your PICL physicians. Dr. Henderson showed hypermobility without instability. PT plus PRP is next step. Great. Yeah, definitely don't panic. Have you done videos of post-Chiari decompression and or pseudomeningeal seals? I haven't done anything on pseudomeningeal seals. Could, but no, I don't have much on pseudomeningeal seals out there right now. Have you seen a posterior, maybe a rectus capitis posterior minor injection re-tear? Can you see this with ultrasound or is MRI required? So I think you're talking about rectus capitis posterior minor muscle. That's the critical muscle back here towards the middle that is responsible for opening the back door for CSF flow around the cerebellar tonsils. I think you're asking whether or not we've seen a tear. We've seen one or two on MRI, but mostly we see atrophy of that muscle. And that's one of the reasons that we treat the suboccipital nerve very frequently during the EPICL procedure to try to get that muscle back online. Dr. Centeno, if someone has moderate intraneural scarring of median nerve, can PRP help? Someone said it won't reach the internal nerve scarring, but can it? You know, I'd have to learn more about what you're talking about with regard to moderate intraneural scarring. That's not easy to see on ultrasound or MRI. What I can say is if we're talking about median nerve function, there's several really good randomized controlled trials on the use of platelet-rich plasma injections to help with nerve function and repair. So we have high-level evidence that that works, but I need to know more about this specific situation. Asking someone else there. For a patient that does too much too soon, which causes a flare, can that have any effect on the ultimate outcome of the PICL treatment? Not usually, no. But I think it can certainly cause a flare. And what you should be doing with that is using it to figure out where you thread the needle, right? If you do too much and you flare up, then you back off and you try again. It's very unlikely that you're going to damage the healing and the procedure. Now, you can take anything to extremes, right? If you want, all of a sudden you start training for the Boston Marathon or to become Mr. Olympic, that's not consistent with this. But the average person is probably not going to do much damage. But it is critical to learn where those limits are so you can figure out how to thread the needle. Yeah, Krista, so this is an interesting one. I'm gonna cut myself off there. So Chris is describing a big flare-up, which sounds like a prolonged flare-up. So Krista, the right thing to do would be to reach out to your doctor to try to see what the best way is to manage that flare-up. And I think you're confusing, again, symptoms with instability. So if PT is causing you to flare up, then you're in that centrally sensitized category. So that's something that would be best to reach out to your doctor to try to see what the next best step is for you. Now, it's certainly possible that you're doing too much, right? Before the PICL, you lived within the functional box. So if we looked at your neck disability index, you'd probably be severely disabled, like most people are who live within the functional box. And you may be pushing it too hard to try to get out of that functional box. But definitely, just like we talked about here tonight, you want to reach out to your doctor, try to strategize. What do I need to do? Now, certainly possible that PICL may not be for you. This doesn't work in 2 to 3 out of 10 patients. So you may be a fusion candidate. And you may need to wait longer for things to chill out and calm down, because we have patients that they're rare, but they happen, where they get 2 months, 3 months, 4 months, 5 months, 6 months flare-ups, and then things calm down. So definitely a good one to, again, not push the panic button, but to talk to your doctor. Friendly, thank you for what you do, doctor. Thank you. I think I answered the other one already. Newly minted. Hi, doctor, a ligament in the back of my skull, I forget the name, that connects to the inion has calcified and has effectively created a biological fusion. So that limits the benefits of EPICL. I think you may be talking not really about, maybe you're talking about a traction osteophyte where the nuchal ligament inserts, and as a result, that's not uncommon these days, but it doesn't really cause a fusion. It's just a traction osteophyte. So I think that's what you're talking about. I need to take a look at the films, but it's usually not a problem, but it does indicate that you've had a forward head posture and that ligament has been pulling on the skull. Talking about muscle inhibition, have you seen any CCI patients with only a heavy head, bobblehead feeling in the absence of other symptoms? How would you approach this? It's possible. Again, one of the things that we've seen over the last year or two is that we've been taking more non-traditional patients now that we know what the risk matrix of the procedure looks like. And those non-traditional patients might be someone like this, right? They don't have headache, they don't have dizziness, they don't have imbalance, they don't really have any other autonomic symptoms other than a heavy head, and they've got instability. Now, first thing to try would be trying to get that person to strengthen, because if that's the only symptom they have, then that would be the direction to go. Now, if you can't get them to strengthen, then you might be in a situation, or we might be in a situation, where we would consider treating those ligaments. Casey, they have a DMX available in Jackson, Mississippi. Would that be okay with you prior to a telemed visit with you? Sure, Casey, a DMX is a great way to start on movement-based imaging. Emily Balfour, you have given me so much hope when I needed it again. I pray I will be able to fundraise to finally get treatments with you and find someone to travel with me. I'm going to work so hard on it. Decade of pure hell, now 28 years old. Well, thank you, Emily. I certainly hope that you can do that. Another thing to consider would be to see if you get chosen or are a candidate for that pro bono program. Blessed. So your procedure you got at your clinic wasn't an EPICL, is a different kind of injections. Don't know if that one's meant for me. Renee, I never got fitted for a hard collar. Is it a good idea to get fitted for one before the EPICL? Could this help with the pain, muscle inhibition? I am a fusion candidate. Yeah, Renee, I mean, hard collars are really a two-edged sword, right? On the one hand, they can certainly help CCI patients with symptoms. On the other hand, they can cause more instability by causing more muscle atrophy. So my sense would be good to try because it's an important piece of diagnostic information, and then not bad to use on an occasional basis when you really need it, but don't get dependent on it. TT, thanks for the answer. What is the definition of disability used to determine if EPICL is appropriate? Do you say it's based on neck disability index? If so, what score, or being disabled from work? Yeah, no, TT, it doesn't usually work like that, although those are possibilities, right? One possibility would be that the person is very functionally disabled, not working, can't work, etc. We have quite a few of those. Another would be the functional box that Krista was talking about, right? We have lots and lots of patients that have designed a functional box for themselves. So they can only function within that box. If they walk out of that box, it's pretty devastating. So they have the appearance of being functional, if you were to look at them from the outside, but what you don't see is all the things they don't do and avoid in order to manage their symptoms. So it could be either of those. Those would be the most common things we see. So there's not a specific score we're looking for. We're trying to take, what's the picture here? Is this person, if they walk into a surgeon's office, going to get a fusion? And if the answer, if more on the rare side, is no, is there a rationale to expose them to a risk of this kind of procedure? Let's see here. I think I'm going to probably start wrapping this up here because we're hitting 6 o'clock and the questions keep coming fast and furious. Okay, guys, well, my light's starting to go here where I am. Thank you for all the great questions. As I always say, there's no such thing as a bad question here. We all learn from all of these questions. And I just wanted to bring up again that I certainly understand that this is a very disabling condition that can make you feel very isolated. I hear that from my patients. I see that from my patients. I feel that from my patients. The reason for getting on tonight was just to say that, this procedure isn't perfect. This procedure isn't magic. There's patients that do well with it, 7 to 8 out of 10. That means 2 to 3 out of 10 will fail. And at the same time, it's critical to understand that if you're struggling for whatever reason, work with your physician, and don't rabbit hole and push the panic button, which is kind of what I see. And if you're going to push the panic button, or if you do need a fusion, your doctor will help you walk through that with you and refer you to someone that they trust to make sure that they do the best possible fusion out there. But obviously the goal is to avoid that fusion in the first place. So thanks so much for taking the time this evening. I'm sorry I kind of switched up the time from Sunday to Thursday, but I'm traveling and I won't be back early enough on Sunday into Denver to try to get this done. So have a great week and a great weekend, and I'll see you back next week.